We've got about 25 minutes now to ask any of the afternoon speakers questions that may pertain to their talks. So while you're collecting your thoughts, I might kick off with a question to the Monash group, Karen and Alice and Stephanie. You presented some beautiful data for us on a dramatic reduction in third and fourth degree tears. But I was a bit surprised when you concluded, I understand the caution, but I was still surprised that you concluded that it may not have been as a consequence of the WHA collaborative. If not that, what drove that astonishing reduction in tears?
The only reason that I put a query as to whether it was due to the collaborative is the timeline of it, because the idea for the collaborative was created during 2017. The first meeting of all of the hospitals participating was in November 2017, and really that was a really initial sort of meeting, and I don't think a lot of the changes really took effect until early 2018. So I think that, maybe the idea of it and the discussion around it created some awareness and some reduction in the rates. But I do think that the changes that had already been made at Monash had an impact on our reduction in rates in 2017.
Thank you. Okay. I'm not overwhelmed by hands shooting up all over the room down here. Thanks, Chairman.
Hi, I've got a question for Roshan. I thought your presentation was fantastic, but I just think it'd be interesting to also look at the trends with reduced fetal movements inductions. Just out of curiosity, I looked at our data very recently, and in 2 years, our induction rate for reduced fetal movement has risen by 167%. So I think it's timely to look at whether we're causing harm by inducing all of this population.
Did you get that, Marianne? There's another PhD there somewhere.
I'm not volunteering.
Yeah, I think that would be something also good to look at. I think it's also hard to measure the unintended harm there, because if you induce the baby and the baby's fine, then it's fine. You won't know if you didn't induce the baby what the actual outcomes are. So it's hard to measure the unintended harm with population-based data.
Nisha.
I'm hoping one panel member can ask another panel member a question.
Of course.
My question is for you, Warwick. There seems to be an increasing trend about VBAC not being safe in hospitals that don't have 24-hour theatre availability. What is your view?
Yeah, thanks. So Warrigal has out-of-hours theatre access within 15 minutes. So because of that, we feel that that's safe. Other institutions in Gippsland don't have that, and it is controversial and ongoing discussion at South Gippsland. Should they be doing VBAC or not? Are you asking my personal opinion? I don't know. I mean, sure. When I'm asked that question, I put it back on the executive of those centres to make that judgment. I don't think it's fair to put it on the clinician to make that judgment call. I think the executive has to support or not support. So I put it back to the clinicians. I don't think it's appropriate that I give my personal opinion.
Coward.
The reason I ask is because, like Bacchus Marsh, I'm sure there are a whole lot of other services who want to support VBAC but have theatre times of 30 minutes, sometimes 45 minutes. And increasingly we are being told, sometimes not so deliberately, that is the wrong thing to be doing. And again, I think it has to go back to the woman and the discussion with the woman about what she would feel comfortable with, and the reality of those statistics of how rare those bad complications are and how we can deal with them safely.
Thanks, Nisha. Ali?
Hi. I just wanted to say, after Nisha's discussion, I worked as an educator. I was very privileged to work as an educator for 6 months last year at Bacchus Marsh. And I think what we're leaving out of the story, every conference I go to, it seems, Bacchus Marsh appears up on a slide under catastrophic failures. And I think we need to stop doing that. It's time to move on. It's time to say it's not a story of catastrophic failures. It's a story of amazingly resilient staff who kept going against the odds, who investigated sometimes for no reason at all, and who kept going, who kept providing amazing care to the women of the Bacchus Marsh region, and who to this day are, dedicated to keeping up their skills, to marching on, to keeping on going. And so that's what I'd like to see at my next conference that I go to, is that if we're going to put up this history, that we're going to also put up the future.
Yeah.
Another.
Or the present. Very nicely said. I completely agree, as I'm sure everyone in the room does. But actually, I'm not so keen to get them off the radar entirely, because actually I think it's a story of success and continuing success. So well done. The miracle, as you've alluded to, is the fact that you kept turning up for work every day. Very intense scrutiny. But there was certainly a lot to be learnt for the sector from that incident, and I think there's still more gains to be had. So absolutely agree. Let's stop talking about the catastrophe and focusing on the learning and the success.
The other thing, I have another question. In relation to Bree's discussion, I'm also very privileged now to be working in the maternity and newborn operating model project, and going out to units far west of our state and talking again to the most amazing practitioners who work under often very difficult situations, very low resource, sometimes having to do very high resource operations while they're waiting for transfers out. As we talk about the IHI initiative coming in, I would like to see that we don't lose our regional midwives. They're doing an amazing job. They are the ones that understand what's going on out there. We don't actually have, when we look at the lights that we've got here, the vegetables and meat that we ate for lunch, it didn't come from Latrobe Street. It came from families way out west or way out east. And something that midwives have said to me, one comment that really hit home was, we shouldn't be offering less to these women than what we gave their grandmothers. And as we start centralising things and losing our regional midwives and our regional experts, we're losing, one midwife said to me, if women don't feel safe, they'll leave the farms, and then we lose the farmer. And as we appreciate everything that we have here in the city, we also need to appreciate what's going on there out in the far west and far east, far north. And I would like to see that when we do move across to IHI, that we don't lose that ability to have senior midwives helping out in those regions.
Yeah. Thank you for that comment. It's very poignant, and as a city slicker, I have to say I come from a different perspective. But having been engaged with the Department of Health and Safer Care Victoria for some time now, I can reassure you that the focus is about keeping mothers and babies together, and the provision of service across the state so that there's equity in delivery of service for all women. And I know it might seem that there's a drive towards centralisation, but actually, Bree can correct me if I'm wrong, I think the point of the regional M&Ms is to try and take some of the knowledge and the expertise to keep services functioning in regional areas and remote areas, so that those services can continue to function with all the fantastic expertise that they have, but with the support of the regional centres. So, Bree, did you have a comment? Or?
Yes, I think it's important to note that when we started the regional M&M process, there were a number of smaller rural regionals that didn't actually have an M&M process in place. So for them to say to them, go away and just recreate the wheel would have been, a huge waste of resource. And I can assure you that the core focus of when we're having these cases and reviewing them is to look at the capability and to think about, is there anything that we could have done differently for some of those smaller places, or to support them from the region? Because sometimes there's a very obvious, in some areas of the state there's extreme geographic isolation, and sometimes people in another part of that region may not be aware that they impeded or perhaps weren't open to collaboration for that particular patient or that particular transfer. So we spend a lot of time looking and thinking about individual needs for those particular clinicians, but also is that the best, if that woman arrives in your birth suite tomorrow, could we do something differently to make sure that there's a positive outcome? And the ability for smaller services to have access to that avenue in a face-to-face way is really, really important, so that we know who these people are, where they're working, what the challenges that they may have been dealing with at that particular point in time.
Thanks, Bree. I wonder if I could just ask Poppy, you alluded to your, in your talk about the very structured approach to women pre-VBAC, about the uncovery of grief and undesirable psychological impact of a previous Caesar. And I'm going to throw it over to Nicole in a minute too, because I want to put in a plug for maternal mental health, which we haven't heard very much about today. But could you give us a bit more detail about just how much post-traumatic stress or grief you are seeing in that process?
Well, I've been a midwife since 1977, and certainly in the time that I've been in Warragul, since 2005, I'm certainly seeing increasing numbers of women with anxiety during their pregnancy, and certainly if I feel the woman may have post-traumatic stress, then that's when obviously she'll be referred. But we really don't have the facilities. We used to have a mental health social worker in our region, and we don't have her anymore. She retired, and really the mental health situation for pregnant women and postpartum it's just not good enough, really, because those practitioners, mental health nurses, are not midwives, and that's where midwifery education regarding mental health really needs to get going, I think. I really do believe that.
Nicole, you want to wade in?
Hello, I'm Nicole Hyatt from COPE, the Centre of Perinatal Excellence, and we specialise in perinatal mental health in the perinatal period. I too am quite amazed that perinatal mental health hasn't really featured highly today in a lot of the discussions. We know the national guidelines recommends that every pregnant woman is screened both during pregnancy and in the postnatal period, and that is not really happening. It's certainly not happening consistently across the public or the private sector. And certainly looking at risk factors as part of the psychosocial assessment, including obviously mental health history, but also previous birth experiences, is all part of best practice. And we still have a long way to go, and certainly postnatal screening with the new recommended screening tools would look at and does ask around experience around their birth and whether that was traumatic, because we know these factors increase the risk of mental health problems both during pregnancies and subsequent pregnancies and in the postnatal period. So 74% of women in the postnatal period do not get help for postnatal depression or anxiety until they reach crisis point, which is why we need screening and assessment, and we need to be really proactive about it.
Thanks, Nicole. So Felicity, I hope you made a mental note next chapter of the maternity e-handbook.
Just a note on mental health and PTSD with previous births. I think as a society, as long as we value a live mother and baby at the end as the only outcome, then I think that we'll never get respect for mothers' mental health when it comes to their birth experiences.
Yeah, thanks for that. I mean, we pat ourselves on the back a little bit because we finally got around to including an indicator that considers the consumer's perspective on what we offer, and that is a big step forward, but it's certainly an area that we're looking to work on and build into future screening and reporting and improving clinical care. So, thank you.
Julianne Barclay from the ANMF. Thanks, Nicole, that was good. Two Nicoles, actually. Look, we have a lot of conversations with midwives and with hospitals about the clinic templates. Midwives, a lot of midwives actually do have some education under their belts. A lot of health services are providing the capacity for mental health screening to be commenced by midwives, taken up by other specialists, but the clinic templates don't allow the time. And so the beauty of what's happening at Warrigal is there's a dedicated clinic, there's dedicated time and there's expertise. And we do have to build our workforce capability, but we also have to allow the time. And I know time is money, but that's what's required in the clinic templates. The antenatal clinic templates across the state are insufficient to provide midwives and women, midwives the time to allow women the time to have the experience that they so badly deserve, which is to be listened to.
Thank you. How many executives are in the room? How many hospital executives? 1, 2, 3, 4, 5, a few. Thank you for coming. I often wonder how we might engage executives better, because there's a lot of enthusiasm within the sector to do a lot of things, but everything's very fiscally restricted. So thank you, executives, for coming. Any other questions? Warwick.
It's a question. It's a response rather than a question. So one of the challenges of going forward at Warrigal in regards to VBAC is succession planning. Poppy is very young, but probably will stop practice soon. So one of the challenges we've got now is to identify younger staff that have the same skill set that Poppy has to try and maintain the service. So I acknowledge there's some deficits in the younger. We realised they were looking at how to address that. And I wanted to more objectively answer Nisha's question and respond to the coward comment.
Good.
I think while professional bodies such as RANZCOG list a contraindication to VBAC as having not 24-hour access to theatre, I think it will be very difficult for those services to be able to justify that practice. I think there is a difference between services like you where there's a consultant obstetrician available despite that, as opposed to GP-run service. I think there's a difference in that risk profile. I would not recommend that those services induce VBACs without access to theatre. I think spontaneous labour, I've shown, the risk is very different in induction versus spontaneous labour.
Yeah, thanks.
Does that address your concern,
yes.
Rob? Thanks.
And I apologise.
It's all right, it's all right.
Alice?
I've just got a question for Roshan, because my other main area of interest as an ultrasound subspecialist is using ultrasound to improve the detection of fetal growth restriction. This might be a bit unfair to ask you, but I wondered if you have an opinion of your own, or can gather the opinion of all of your colleagues at Safer Care Victoria about the question on your last slide, which was how much can we sacrifice in order to detect or improve the detection of growth restriction? And do you think it's worthwhile inducing everybody at 39 weeks just to reduce the undetected growth restricted babies?
I would probably refer to Marianne, but I think it depends if we value mortality versus morbidity. And I think by increasing focus on FGR, we will improve mortality, but it will also raise the morbidity for severe FGR babies and also normally grown babies. So I think there's a choice of which we value more, and I think mortality seems to be the more right option, in my opinion.
Yeah, that's a sensible view. Alice. Fortunately, we know from Monash that we've reduced IV antibiotic rates to newborns by 76%. So the nurseries are all empty. You can afford to deliver the occasional small one that's a bit sick, and we'll just shove them into one of those beds. Where's Michael Stewart when you need him? He missed it. It was wasted on him. Any other questions?
Sorry, Rod, could I just add to what Rashan said? We could, it's certainly the way to get a zero result on that indicator is to induce everyone before 39 weeks. This is not the only morbidity that's possible by early birth. There's been evidence from Sydney, and we're going to do some more work in Rashan's thesis about developmental outcomes for people who are late, early term babies. So for each week earlier, is there a price to be paid? So we don't know the full picture yet. I just think we'd need to keep that open. Certainly everybody wants to take home a live baby, but I think the focus should be on improving ways of detecting growth-restricted babies more specifically, so that we're not inducing babies at the 50th centile for fetal growth restriction.
I just have a question as well for Rashan. So we're hitting you, aren't we? So obviously you've concentrated on the severe growth-restricted babies and the unintended consequences, but we also know that there's babies that fit into the normal centiles that are also growth-restricted who are potentially meant to be bigger babies and are growth-restricted and are at risk of stillbirth. So those numbers of unintended consequences, is there potentially some of those babies who have been induced quite appropriately for falling centiles that fit into your cohort?
Yeah, we can't adjust for that if you're above the 10th centile, but it is unlikely that that represents 50% of FGR babies. If I were to say more than 50% of FGR babies are below the 10th centile. And we also can't adjust for constitutionally small babies that are also below the 10th centile and are healthy. So it kind of balances out.
Maybe I can throw one last grenade from the lectern before we hand over to Ewan. I'm an neonatologist. I am not an obstetrician, and I have the greatest respect for my obstetric colleagues, and I appreciate that obstetric ultrasound is a very highly developed skill that takes a long time to acquire and a lot of expertise to do well. But can anyone tell me how it is that babies who are over the 50th centile are being delivered suspected of being the 3rd centile? Is that it? Yeah. Thanks, Alice. Good on you for wading in. And it is a genuine question of ignorance because...
Yeah, I think all ultrasound specialists would like to say that ultrasound's perfect, but we all know that it's not. And there's a very wide margin of error with estimated fetal weights, and that increases the bigger the baby gets. So a baby on the 50th centile is going to have a wider margin of error, I guess, than a smaller baby. And so there has been a lot of work lately on better ways to pick up growth-restricted babies, and I think we're getting closer to an answer in terms of picking up evidence of placental insufficiency with abnormal Doppler studies. And we don't have a perfect way to pick up a growth-restricted baby, but there are much better ways than just looking at the estimated fetal weight. And I don't think that obstetric practice has caught up with that yet. And especially the indicator that we're using definitely hasn't caught up with that yet. Because it's hard to make a new indicator based on the number of factors that you need to take into account in clinical practice to pick up a growth-restricted baby.
Thank you.